Hello, all. Welcome. Welcome to this new normal in dentistry, the South Asian perspective. I welcome you all on this summit. There is a need to stop and the need for clear guidelines to practice dentistry. All of us were shaken by the WHO declaring that there is a public health emergency of international concern in January 2020. This was followed by the New York Times article in March of 2020 saying that the workers who face the greatest coronavirus risk are the dentists. So all of a sudden, our dental life came to a stuttering halt. Now, how do we recover, or how do we come up with dentistry again? So there were many gurus, there were many lectures on COVID. There were a lot of uh, webinars happening on how to cope with the coronavirus crisis in the dentistry. However, there was lack of scientific evidence. A number of publications were done. For example, all of you know that HCQ was propagated as to be taken and then withdrawn. So a lot of it's called the butterfly effect. What happened? That a lot of publications came, many were withdrawn. There were new acronyms which all of us heard, like aerosol procedures. We learned about PPEs. So all of us as dentists were not used to this scenario. There were guidelines or SOPs pouring in from everyone, from ADA to CDC to the dental councils, ministries of health, and there were lot of pandemonium around. However, the joke going around the corner in August is, after 6 months of or 8 months of this pandemic, is WHO says avoid dental appointments. And when you just remove WHO as all caps, it says who says avoid dental appointments. So basically, the issue is that there is a lot of confusion, and the objective of today's webinar is basically to address the concerns and to come out with the logical guidelines. All of us are learning, unlearning, and we are coming to a consensus about how to practice dentistry in this era. Well, this program is unique. It's unique because of two things. Firstly, the event is an example of true South Asian collaboration. India, Pakistan, Bangladesh, Nepal, Sri Lanka, all great speakers have come along, they've gelled together, and they will be doing a presentation and coming up with answers of the questions which have been posed. The second thing is that it's a first of its kind event that has been organized by the joint collaboration of Media India, who are the publishers of dental practice and dental technology journals, along with Dental News Pakistan and MIMS Bangladesh. So, it's a joint collaborative effort, and I wish all the speakers a grand success. Well, the first speaker in this journey today will be the renowned Dr. Irfan Qureshi from Pakistan. He is a practitioner in Karachi with his MSc in prosthodontics from the King's College, a diplomat of implant dentistry from the Royal College of Surgeons in Edinburgh, a diplomat and an ambassador of ICOI, a fellow of IDIA and WAUPS. He is the practitioner who didn't stop his practice even for a single day throughout the pandemic. So, right from the horse's mouth, you will hear how dental practice in the COVID era has evolved. Welcome, Dr. Irfan Qureshi.
Thank you, Dr. Puneet. Everyone can hear me, just checking?
Yes, sir.
Excellent. Okay, thank you for the opportunity to the organizers, especially Hashim Bhai from Dental News Pakistan, for giving me the privilege to share a stage with such illustrious colleagues. I'll get straight to the point now. Okay. Okay, so this is stuck right away. Okay, yeah, there you go. So I'll get straight to the point. Life was simple. We were going about our normal lives, and one day we wake up and the world has changed. And we all know that COVID changed the world, and there's a lot of talk about the new normal. And my 2 cents about this new normal is we really have to ask ourselves a question, hand on heart, and reflect. Were we really truly following what was supposed to be the old normal. And if you think about it, the new normal is only very slightly different from the old normal. There's a lot of dentists who have been culprits for a transmission of disease among patients, and especially in the third world where there is very less accountability. So we learned the hard way. Dentists were also not spared when coronavirus struck. And we learned the hard way. We had to really face closure. A lot of offices all over the world were closed down. And there was an economic toll that was taken on the lives of dentists. And only then were we really forced to think on how to get out of this situation. So, what did COVID 19 teach us? And we have to, I want to highlight this point. You know, viruses have survived millions and billions of years because of their ability to evolve. And as I mentioned previously, it's only now when we are pushed against a wall that we have been forced to think outside the box and think survival. So you have to stay one step ahead of potential disasters that will strike us even in the future. And the corona shockwave was felt around the world. There were burning questions. Should we be treating patients? And you know, it was all over the internet, lots of content, and there was talk of treating only emergencies. Okay, fine, let's only treat emergencies. But what constitutes an emergency? I read a lot about, you know, let's just treat uncontrolled bleeding, unbearable pain, and swellings, and call those patients to the office. But then try telling that to, say, a young lady who's knocked out an anterior Maryland bridge. Try telling her that she does not fall into an emergency and she should sit tight at home until things improve. So we couldn't really close down even for a single day. Something or the other was happening every day, and we used whatever we could get our hands on for personal protection, for the protection of our patients. And we stayed on duty trying to help our patients and be there for our patients. And once finally the dust settled, then we were able to sit down and think and formulate a protocol. We were also trolled a lot on social media for remaining open. There were lots of criticism. So how did we come about to this protocol and our approach? And I want to quote Arnold Schwarzenegger's trainer, Joe Weider. You have to be obsessed. A guy like me, who's a neurotic, so I actually have a field day because I'm going crazy. And we have a three-pronged approach, ensuring personal safety for ourselves, safety of the premises, and ensuring that the patients feel safe with us. How do we achieve that? First and foremost is that the patients should feel safer at your practice than they even feel at home. I think that's a very important message. And for personal safety, the first thing that we do for all our staff members, doctors and staff included, is every single person who's coming to work has to get PCR testing done every 2 to 3 weeks if they want to work with us. And we all wear PPE suits, we're training and retraining, educating and re-educating our staff. We have discussions every day. I'm like a nagging mom running after our staff members, trying to tell them the importance of social distancing, not letting them eat together, not congregating together, avoiding non-essential travel, non-essential socializing, etc. So all of this, discussing diet, staying healthy, and we're not compromising on these. So I've hired people whose only job is to clean, sweep, scrub, wash, sanitize every hour and keep repeating it neurotically. If you're a clean freak, this time is Christmas time. Okay, go nuts. So we've installed air purifiers. We're using hypochlorous acid, which I will also talk about. Rubber dams, which is standard of care to begin with. Like I said, rubber dams was old normal too. And again, no compromise. So we're also talking to patients, educating them, restraining them diligently, and I will show you how we are doing that. How do we put all of this together? So I put together this little pictorial to show how we are doing this here in my office. This is our front desk area. It's a spacious front desk, and this is the receptionist. The patient experience starts when the receptionist calls the patient for the appointment. And what you see lying next to the coffee machine, this little guy, is an interesting device. It sprays a hypochlorous acid-based mist, which is very safe, and it's very helpful in decontamination. As you can see, it's controlled by remote. So the front desk guy will come and clean up everything. And on the bottom left of your screen, you see an air purifier, cute little guy right there. You can also see we've placed signs on the seating area where patients are not allowed to sit, and we're encouraging them to practice social distancing. So spacious waiting area, social distancing, and it's always very helpful when you have a pleasing, welcoming premises. This is the patio of our clinic. When the patients arrive, this is how they are welcomed. As soon as they enter, there is a guy just at the entrance who's fully covered, and he's holding his gear. He will help the patients to sanitize their hands. He will offer them gloves. Then a staff member will come who's also fully covered in 70 GSM PPE, and she will cover the patient in a 70 GSM sterilized PPE gown. So that's how it's done. And then a staff member will disinfect the door handle for the patient, and the patient then walks into the reception area where the receptionist will take the patient's temperature with a non-contact thermometer. And then he will even disinfect the pen that the patient will be offered to fill out her patient card. So it's attention to detail, small little things. And then the front desk receptionist will spray a disinfectant onto the seating area where the patient will sit. So all these things are very reassuring for the patients. And this is the another COVID-19 related history form that we have designed in addition to all the other information that the patients fill out. And I'm happy to share this with the colleagues if they would like me to. So the patient is then escorted from the front desk to the surgery. And we have additional waiting areas in our premises also where we encourage social distancing. And these are also misted down, as you can see, with the hypochlorous acid. So when the patient enters the surgery, an assistant will spray a small basket, a nice looking small basket with a disinfectant, and ask the patient to place their personal belongings like cell phones and keychains. So again, the patients feel reassured. So these are our surgeries. From the start, because I was always a neurotic about hygiene and cross-infection control. So we made bigger surgeries, which were well ventilated to begin with, and they've been greatly helpful. And the surgeries are also, sometimes we run these mist machines in front of the patient. It's a nice dramatic effect also, and again, it reassures patients, makes them feel safe. And again, for reassurance of the patient, the assistant, who's also fully covered, you can check the attention to detail, armrest, etc., are fully covered with the protective tape. And the assistant will scrub the chair with the disinfectant before the patient is seated, and the patient is fully covered. And then, and only then, will the doctors wearing full covered PPE suits and the assistants wearing full PPE suits will proceed with treatment. We are using rubber dams. We were using them even in the pre-COVID era. And initially, we were using N95 masks, which were difficult to reuse and they were difficult to acquire. So we then switched to these industrial-grade respirator masks, which have replaceable filters. We've also invested in these aerosol aspirator machines. And until they arrive, what is standard practice in the clinic is once the patient has been treated, once they leave the premises, the surgery is emptied out, windows are opened, and fans are running just to flush out as much aerosol as possible. Nobody goes into surgery for the next 30 to 40 minutes. So this is a very small pictorial of how we do things. We have additional 4 surgeries in the clinic as well. All surgeries are big rooms, ventilated, spacious, and they're also misted down, as you can see. Air purifiers are placed in each surgery, and the staff is trained and retrained every day. We nag them all day long to get used to this new normal. I just want to make a couple of last comments before I finish my little talk. What was very disappointing to see was what I call decay of humanity. The way our vendors, our suppliers, sellers were giving out and selling sanitizers, masks, gloves at exorbitantly high prices, and the way the situation was exploited was heartbreaking to see, and this needs to be addressed. Um, Another important aspect, which I personally also felt, is dentistry is a difficult profession. There is a high prevalence of burnout among dentists, stress and anxiety. Even in the pre-COVID era, if you search the internet for publications, this is rampant among dentists because you're essentially in a career where no one wants to see you. Everyone who walks into your office tells you day in and day out that they hate being here, and you get to hear this every single day. It starts to play on the mind after a while. So, dentistry, the stress can kill you. And COVID 19 has not helped the situation anymore. And this is something which I feel that the dental community and colleagues and professionals can come together and really try to help each other in trying to manage our psychological health, our emotional, and our mental health. So I leave you with this quote by Mother Nature. If you want to survive, if you want to thrive, you have to be willing to evolve. These are contacts where I can be reached on. Thank you very much for listening to me. And Puneet, I hope I have not overshot my time by too much.
Perfect. I think you were too good. Uh, in fact, I'd request you to stay online because there are a few questions pouring in for you. In fact, you have very nicely outlined that the clinic design has to be altered to in order to combat the COVID, infection. But there are two questions which have come up. First one is that do you have to modify the air conditioning, or are there some regulations? The ACs. I could see a wall-mounted AC on your operatory. So, what kind of air conditioning system would you prefer?
So this is a interesting question, and that was also put to me before the session. One suggestion was having negative pressure rooms. The problem with negative pressure rooms is that it kills the air conditioning. And in Karachi, the temperature this summer has gone up to beyond 40 degrees Celsius. And we're working wearing PPE suits. So until something concrete comes in terms of how to deal with air conditioning, this really is a gray area. What you can do is work around it. Like I said, go neurotic with disinfectant sprays. That's why we acquired these mist machines. And hypochlorous acid, by the way, is something that we need to read up a little bit on because that apparently is helping in cleaning the environment. Air purifiers. I think, you see, there are hospitals, by the way, with centralized air conditioning plants, and they have these valves and ducts. And a lot of these WhatsApp messages are floating around that even these ducts can transmit the virus. I mean, by the way, having said that, I'll also tell you, in the last 4 months, and we have religiously been getting tested every 3 weeks or so, despite the fact that we're literally, we have our faces in the patient's mouths, none of us so far have tested positive. So, by the grace of Allah, I think we're doing something right.
Another question which has just popped up is regarding biomedical waste management. Your operatories are very nicely designed. Any changes you've made to that? Because one of the viewers has commented that since you are making the patient also wear a gown, there's a lot of biomedical waste to be disposed of.
Absolutely. So, what there's a question, it's a question that even I have been asking, and it's a question that we all need to ask. All these masks and PPE equipment which is being sold is not biodegradable, is it? So all this positive talk of lesser travel and lesser air pollution and the air clearing out, how is all this waste, billions of masks being sold, where are they all going to go? What we do is, I'll tell you to answer your question, we're actually quite fortunate. We're in a practice, my practice is in a place called Clifton in Karachi, and we are right next to a hospital. And the hospital has an incinerator. So we have a staff of about 29 people. in the practice. We are a big practice. It's a 500-yard premises with 2 stories. So we have a lot of staff for this. The PPE suits, by the way, are not reused. We don't even. There are a lot of people I know who are washing them and they're reusing them again. We get rid of them. So we get the hospital personnel to come and pick it up and use their incinerator to dispose them off. Now we were doing this. We were not wearing PPE suits, to be honest, in the pre-COVID era, but we were using the hospital incinerator for our masks and our gloves, even pre-COVID. So, like I said, really, hand on heart, ask yourselves, we've only been pushed now to be doing what we should have been doing all along.
Thank you, Dr. Irfan. I think while we have the panel discussion towards the end, we'll again connect with you. I would now like to request the second speaker on the panel. That's Professor V. Gopi Krishna from India. He is a founder director of Root Canal Foundation based in Chennai in India. He completed his PhD in the field of endodontics from the Dr. MGR Educational and Research Institute University in the year 2017. He is the editor-in-chief of Endodontology Journal and the associate editor of the European Endodontic Journal. He is also the general secretary and the clinical examiner for the Indian Board of Endodontics, a very renowned endodontist who is an editor of 6 textbooks, including the acclaimed Grossman's Endodontic Practice. I request Dr. Gopi Krishna to share his views.
Thank you, Puneet. Am I audible? And I need the previous presentation to be stopped. Otherwise, I will not be able to share on my end.
Can Dr. Irfan, can you stop your screen share?
Can you stop your share screen for me to come in? No, it's not allowing me while the other person is sharing his slides. Okay, now I think I can. Just a second. I'm on. Okay. And because your host has stopped the video, so it's not on my end. Is my slides visible and my audio okay?
Yeah, perfect.
Okay, exactly. Yep, there we go. Is this okay? Shall we go?
Yes.
Yep. Thank you. Thank you for the kind invite. And it was a pleasure listening to Dr. Irfan from Pakistan and for him to share his views. And I will take things further ahead. And it's a wonderful platform of various clinicians across South Asia to get together to present our views. So I would be taking things ahead from where Dr. Irfan has told us about. The first insight which I would like all of us, the viewers who are sitting in South Asia, to see is currently today, worldwide, there are 3 huge clusters of these cases. So yes, 2 points. First, take home, there are no dental clusters. Dentistry has not been recognized as a cluster for transmitting cases. So dental practices are not going to cause transmission. So that's the good news. But the bad news is your patients can bring the disease to you. Why? Because you and I live in the 3rd largest cluster of cases on earth. So simple mathematics, the probability of a patient coming to a practice who is asymptomatic and probably transmitting it to us is more than we as dentists transmitting the disease from our practice to others. So you need to obviously to ensure that as far as possible that there is some amount of triaging. Right now, for the last 2 months in India, we are practicing full-blown. Even I'm going to my practice every single day, and I am seeing 6 to 7 endodontic procedures. And me and our team are safe. But we do one thing. We always make sure we speak to the patient. We do the 3 A's. We advise the patients what is the problem. We make sure that we space the appointments and we call them only when there is a requirement. So we are planning our schedule much more meticulously than before. The most important point when a patient enters your practice is to consider every patient as a carrier. I simply assume that everyone is a carrier. The only thing is they might be asymptomatic. Like Dr. Qureshi showed, we also do pulse oximetry, we take the temperature, all. But the point is, most of these patients who are transmitting the diseases might not have these symptoms. So that's the challenge we would have. So the most important solution for that is to have certain kind of practices in your clinical work, wherein you can ensure that the patient is not bringing an infection and transmitting to us. To me, my take-home point from my presentation is this: we need to protect ourselves. We are not the transmitters, but we need to protect ourselves and our team and not end up as transmitters. So hence, spacing of appointments and avoiding the strict no-no for walk-in patients is the most important. The other aspect I was asked to discuss in this short 5-minute lecture, which I'm supposed to give, is on the importance of COVID testing. Right now in India, there was a huge emphasis on doing the more commercially easily available antibody testing, which is what everybody likes to do. It's very economical. You get the result within an hour. But to be frank, it has got a very high false negativity. Hence, I would say that this is the test which is there, which is more useful for now. The understanding is to find out if you had a history of COVID, it's more useful for that, but not for the diagnosis of having COVID. So the test which we need is RT-PCR, which is now the standard gold test. Even that, the false positive rates are up to 20 to 25%. Hence, I'm just giving you one single sheet. If you go to this website, I think this is the most updated sheet. If you want to know more about testing, you just go to this website and you get what is the guidance. Simply put, antibody testing is only done if you want to find out the history of whether you had COVID infection, just to get to know whether your antibodies are there or you are still infected in your history past. But for you and me as clinicians, or people who are going to do, I think if you want to test anybody, you need to do the viral testing, which is the RT-PCR. Current recommendation, only 2 times you need to test. Anybody who's symptomatic, who comes to you or whom you know and you're worried, you need to get them tested. And asymptomatic is all healthcare workers. If you are or anybody in your team is getting symptoms of cough or cold or fever, I think the whole team has to get RT-PCR. So you can set a protocol. I would not go to the extent of testing myself every 2 weeks. I have not done that. But yes, if there is a person in the team who's getting symptoms, I think it's prudent for a practice to get all of them tested periodically. Coming to the core area where I was supposed to talk was on aerosols, and we create aerosols. Dentistry is aerosol. So without aerosols, there is nothing we can do. And that's the reason why WHO and everybody panicked, that because of dentistry, we might be disease transmitters. But you know what? Barber shops, vegetable vendors, and all malls, cinemas, all religious congregations, that's been the disease generator and transmitter areas and not dental clinics. So the key point for you and me to understand is I'm been using aerosols. As an endodontist, I cannot work without aerosols. I think endodontists and prosthodontists cannot, and periodontists too, we cannot do any procedure without creating aerosol. So as I would say is, yes, so we would be creating aerosols. And what is the problem with the aerosol is the size of these viruses are so small that along with these aerosols, they can stay in our dental operatory for much more time. So you can put on your rubber dam, you can do many things, but before that, if there is aerosol which is generated, this aerosol in your closed room can cause a problem. And that is the where I'm coming to. I have a nice swanky practice in Chennai. Everybody raves about it. We are very highly rated. I have a huge space. But what about the common dental clinic in South Asia? In Bangladesh, in India, in Pakistan, 90% of clinics are one-room clinics. There are something like this. This is not my operatory, but a clinic with 2 rooms, 2 chairs outside, very close space. And inside you have 1 chair, everything is enclosed. You have an air conditioner which runs all the time, and you are breathing the same air again and again. So the problem of if you are going to get infected is because of the air which we are going to breathe. The dentist, I feel, is the one who is at risk and not the patient when it comes to COVID in this era. So the only way you can do is to understand how you can improve your air circulation, which is what we focused on in India. I was in charge of creating this SOP for our society and as well as for the international body of endodontic associations. And what we recommended more than 3 months back is what the whole world is now recommending, that you need to improve airflow circulation. More than anything else, the air in your room, there are only 2 things where you can get infected. One is by touch or when the patient coughs on your face, which we are protected because of our PPE. But what about the air which we are breathing, what the patient is breathing? Hence, if you have a clinic, no matter big, small, or what, and if you are like anybody else in Asia, South Asia, you cannot practice without an air conditioner. So for people who do not have air conditioners or who have got clinics which cannot afford HEPA filters, then the only choice is to have pedestal fans and exhaust fans so that you can suck in air out of your clinics and do. This is a solution which looks very simple, but that is the only solution you have if you cannot invest on something which can improve the air quality in your room, is my 2 cents. So like anybody else, you need to have a dental protection unit. Instead of a PPE, I would say a dental protection unit, a DPE, which is more about your face. And it basically is the face shield. In the limited knowledge we have, I personally think the number one protection for us is the face shield which we are going to use. That's very important. And then obviously comes the masks which you're wearing, N95s, or you can also use the industrial respirators, one of the two. There are other reports to say again, which is coming in more and more, which says that changing the mask and making sure the face shield is there to prevent the splatter to hit you, because the virus is either going to come through contact through the splatter or through the air which we are going to breathe. And this is what we do. So this is what I work. So I have a HEPA medical grade air purifier in every operatory. So when we work, the air is getting 12 air changes per hour. That's the purview which we would recommend. And then you can go about, do your work, sterilize everything, and then go about. And this is what I've been doing day in and day out for the last 2 months. So take home points in this quick 5 minutes is this, 3 points. Testing strategies is need-based. I would not say it's empirical. I would not recommend it as a routine practice. I would only say do it as need-based. Triage your patients and plan your appointments more meticulously. If you are like any good practice, planned well. I think if you're planned well, I'm seeing my workflow improving every day, every week as I go back to practice. The only thing which is different is obviously an added layer of protections which we are putting. And I think that's good for you and me in this era. Lastly, aerosol generating procedures, which is what everybody is worried about, is absolutely safe. And if you can go ahead and do it, and I do not see, as of now, in the whole of the world, in Korea to Japan to into all the parts of Europe and US, there is no report of aerosol generating procedures in dentistry causing any kinds of transmission. So I think dentistry is safe with extra precautions. I think our future is bright as ever. I thank you all for this wonderful opportunity, and I would be ready to take some questions right now, Puneet. Thank you.
Thank you, Dr. Gopi. It was wonderful how you summarized how to tele-triage your patients and how to make a protocol for testing. In fact, the first question which we have for you is on testing strategies. The question is that what is your flow chart of which patients should you get tested and which patients should not be?
I would see the question of testing is basically in dentistry, to be perfectly, if you ask me, I would only recommend for patients who have had a history of travel, and now there is absolute travel ban. So if you ask me, the whole question in dentistry, it's a personal take. Now, if you can ask, would I put all my patients under testing? The answer is no. I simply do not allow them to come into my practice if I know if they had a history of a fever or anything which could be there. Because now we realize that 75 to 80% of your patients would be asymptomatic. And these asymptomatic patients cannot transmit the enough viral load to you in that 45 minutes of period if you take the due precautions. So it's like me asking you a question, do you test for HIV for every case? Do you test for hepatitis for every case? The answer is no, you do not. You take more precautions. So there are two ways of looking at this question. A, test everybody and bring in only those people who are going to be negative. This strategy is useful for a country where they are going to have immigration controls. So you travel from A country to B, now they have putting you that you need to get a negative and come inside. But whereas for a dental practice, I would say, unless if you want to do testing, then the only way is to do an RT-PCR. And to get a RT-PCR for every single patient, I don't think it's practically feasible in South Asia. So there are two ways of answering this. One is an academic way and one is a clinical way. So I would rather say set the protocols, keep yourself safe, and then I think periodically testing yourself and your staff, if anybody in the team, it's very important. If you look at the CDC guideline, they're very clearly saying specifically, test the team if anybody in the team has a history of symptoms is more practical and sensible. And this is what the US CDC is giving us. And I think that's a fair enough recommendation for all of us to follow.
I think you very perfectly summarized whether to go for testing or not. The second question, very short one for you, is that are there some, we are talking about teledentistry. Are there some, is there some law in South Asia regarding teledentistry, or we are still evolving?
I would say there's no specific law, but right now the one important improvement, at least in India, is that you are allowed to give prescriptions or through teledentistry or by WhatsApp, or you can image and do. Earlier, you need to give a physical prescription, and then only the pharmacist was allowed to give you, and that's there. But I see there's a huge scope of teledentistry, and I think many softwares have already evolved. And even today morning, I had a couple of patients who are sending me or doing a video call and talking to me. And it actually, if you keep a couple of people in your practice, couple of my dentists in my practice are slotted for this. So what it does is they are doing the basic consultation, which you would normally do when the patient comes to you and talks. So the talking time between you and the patient is reduced if you strongly follow teledentistry. So that really makes the time less for you to talk. And talking to the patient with your N95 and respirators is a huge ask. If you ask me which is the toughest thing to do, is to talk to patients when you do the procedure. So I personally don't like doing that when I'm wearing this, because you will feel exhausted when you are trying to talk with the respirators on. So teledentistry is fantastic in not only filtering your patients, but also trying to get the other intricacies and information that you would need before they walk into your practice.
Thank you so much, Dr. Gopi. We will get in touch with you as soon as the panel discussion starts.
Yep.
Thank you so much.
Absolute pleasure. Thank you.
I'd like to introduce the next speaker. That's Dr. Neil Pandey from Nepal. He has been in private practice in Kathmandu in Nepal for the past 24 years. He manages 2 successful practices, and his areas of interest is restorative dentistry as well as implantology. He is the current founding president of the Nepalese Society of Implant Dentistry. Young and dynamic, and one of the leading faces of dentistry in Nepal. Welcome, Dr. Neil.
Thank you, Dr. Puneet. Thank you for that opportunity to do this, area, South Asia, where almost 2 billion people live. And I hear almost 3 lakhs dentists are there. And to be able to come out with some kind of synergy between the neighbors, this is a beautiful thing. And I think it's a great start, and COVID actually brought us together, and online could be made so much possible. And thank you for giving me this opportunity. First of all, now, as all of us, COVID actually woke us up, all of us, in a different way. We dentists, in a way, if you look at it, have always been bathing on that aerosol. We knew about that aerosol. We knew about all the infection control, and we did practice that. If you look at between the medical care sector and ours was always masked, and other protections were PPE. We used to call it, in England, whenever I was doing my membership exams, and PPE was that. Now this is added PPE, the aerosol issues. That COVID has woken us up, which is actually great opportunity for dentistry to upgrade, I would say. Yes, we are having hardship, but we are protecting ourselves now for the next thing that is going to come. And thank you to our Dr. Irfan and Dr. Gopi for highlighting so many areas. I'm going to go on that again. Mine is a story that I have faced myself. So this is my own story. Now, this was a virus which was 500 to 600 times smaller than our human hair. And we had a main challenge. Can we work within 6 feet distance? Can we have a aerosol non-producing procedure? Very much not possible in dentistry, right? And our mask, for a simple surgical mask, which we know today protects others, but does not protect us. So there were barriers, and even the N95, which is 0.3 microns, it can prevent, and the virus we're dealing was 0.125 microns on an average. And fomites, of course, we were always cleaning up with spirit and all that. We were doing all that. And thank God, COVID is not that strong, that thing, but at least it gets killed, denatured by a simple thing like a spirit, 70% alcohol. Going to, like all of the dentists around the world, we started our own thing. Now, what is it? We dentists sometimes tend to think we know everything, right? And we started finding out various things. Sometimes we even started cutting that mask and checking out how it is. We even fitted our own ventilation system, PPEs and guidelines and webinars and whatnot. But whenever it comes to specialization, I feel, and we always have been practicing in dentistry also, if you have an endo problem, you may want to refer to an endodontist, which is complicated endo, you may want to refer to endodontist. Similarly, this complicated problem needed a scientific solution. And what I did was I went more towards figuring out my airflow, figuring out my workflow, and approached an HVAC engineer and architects to actually figure out, hey, how to get rid of this aerosol. Of course, mask was always a problem for us. Like Dr. Irfan said, we were not getting FFP2 or even FFP3. FFP2, what we're getting even now is only one we get, that is BYD, which is NIOSH certified. Rest, we don't know if they're working or not. So we are all still in a lookout for FFP3, which has been a guideline in the United Kingdom and other countries. So my aim was to make my 2 rooms very negative pressure, at the same time donning and doffing separate areas, and reception segregated from the entire clinical area. So what I did was I started working. So we made the system from Ukraine. We fitted this with an aim to do that. And thankfully, around 10 days ago, we finished the whole process, and we actually this whole webinar pushed me to get it fixed sooner. And I feel a little more safer. I feel my staff feels safer. That is most important thing. And who are we making? Patient, staff, our families, and even the surroundings safer. So even the air that goes out from these negative pressure so-called units have to be filtered, have to be UV light things, so that nobody outside also gets it. So what we did was we just made a simple process, and this process now, Hashib will go on with a video. He will just put on the video for me. I will show you the process, what exactly I did. Hashib, can you? No, that's my video. I haven't started the video. This is just a preview only. Can you start the video from your side? So what I wanted to show you, what I would like to share with all of us here today is what I actually did. Maybe there are a lot of things I am not being able to get in my head, but my always thinking was aerosol. Get that bloody thing out of the room, get that thing away from us. And the airflow. So whenever we make the airflow needs to be at the floor level, not at the higher level, because whenever the air is flowing more towards the higher level, you are supposed to be getting in inside your nose. So naturally, lower level will be better. And that was complemented by all these COVID wars that were made and all that. That also did the same thing. Hasib, can you please play the video? It's still in the thing. Yeah, it's running now. Are you running it? Yeah. So anyway, let me go on then. You have to give me grace time for that when you found that, okay? Because I had taken the video out from my presentation, so I'll see you play that. So anyway, aerosols. What we've done is simple processes, the triazing, and I've used some kind of online forms and screening and tele-dentistry. All that has been employed. One thing I've noted in a lot of our practices around is people are wearing PPE, people are doing all that, but they were actually not changing the PPE. So that is one of the things that I wanted to highlight. Oh, they can't hear me? Okay. Great. So donning and doffing, I mean, this is a boring procedure for most of the people because you've been doing that, but it is so important. It is so important to make sure that your mask is all the time on when you are inside that clinic, inside that clinical area. N95, and you wear your mask, your shields, your no belongings. I try to treat the reception as a pre-operative area, like in the surgeries, and the other what do you call, the surgeries are real surgeries, so minor OTs kind of thing. So that this is also, as I said, to upgrade dentistry in the eyes of public as well. Oh, the standard of care has to go up. I know it's not possible everywhere else, but if we as leaders of dentistry, if we show certain ways out, I'm sure others will slowly try to adapt. So once the patient is done, we try to get the Now, the most important feeling, I mean, it's the doffing procedure. During the doffing, what is happening is a lot of doctors getting infected, they're saying, is during the doffing procedure. They're tired, they are worked out, and when they're taking off the whole bloody PPE, the flying of the trajectory movements that can get the other person infected. So there is this thing. Very, very slow doffing. This is extremely important in our scene. And what we do is, after doffing, it is placed straight into a detergent with a hypochlorite, 0.1%, very easy to make. You take 5 liters of water and 1 teaspoonful of chlorine, and you try to, that will added benefit. Nice detergent. You soak that in for almost 1 hour in there, very slow, and that's how we go about. Then there you go. I mean, fomites needs to be taken care of course. So immediately after the patient goes out, we try to clean the area up with, of course, it's let the room, let it be for like 1 hour, 60 minutes. And again, 2 times, I want them to clean it up because it's not enough. So as I showed you the flow, as you see the system. Now I'm going to show you the system. This is what we've done. All homemade with a technology, like the machine is from Ukraine, but rest of all the apparatus is made here by our engineers. It's ended. So, looking at, okay, then I started looking. I did it a little too early. I mean, just thinking out of my head, I felt, but there was a lot of talk going on. And I was very happy to find this literature, which just came out on 13th August, this little study, where it did show, yes, with the employing of these kind of negative pressure, we are able to get some kind of aerosol out. And the Scottish have just come out with a guideline of if it's more than 10 ACH, your fallow time or interval between patients is 20 minutes, whereas if it's less than 10, then 60 minutes. If there is no ventilation, you are not supposed to do any aerosol generating procedure at all. And especially in a time like this, especially in a place like Kathmandu, where we are absolutely in red, we are actually not doing dentistry as of now. We are in a period of fallow period, let's say that. Now, ladies and gentlemen, at the end, I would like to give you a simple message, take-home message. I call it safety first message. And our main enemy here is aerosol. Of course, corona and the aerosol becomes a medium to fly. Let us not allow it to enter inside our systems, right? Let's use physics. Let's use experts. Let's not be, at times we dentists want to be everything. But let us take help of engineers and other guys to figure out the airflow and all that and evacuate these safely. And understanding the enemy and adapting to live with it is our new normal. If you'd like to find me somewhere, I'm on Facebook with Pandya.Neil. Thank you very much for this opportunity.
Thank you, Dr. Neil. A wonderful presentation on how to minimize aerosol. Well, a few questions have popped in for you, and we'll need a quick answer so that we can proceed further. First is, do you reuse your N95s? Like you mentioned, that very difficult to get, masks available.
Yes. Yeah, absolutely. I mean, now we've got a BYD mask, NIOSH approved one we are getting here, but it has been very difficult, yes. So we use that, we use the surgical on top. We've been doing that. But on a lookout for N99. But, I always say whenever it's difficult to breathe, that means it's working.
Right. Perfect. And the second question which is there for you is that is something like an electrical handpiece of any use for minimizing aerosols?
Well, I've been using electrical handpiece for almost 3 years now. And, it has its water, it has its thing. So, water directed towards the tooth and flying over, I don't think that's an answer, So without water, you may be able to use, slow speed or whatever. But, of course, rubber dam and all that, that's the main thing. Of course, we've been using that also for our certain procedure. But frankly speaking, we're trying to limit the time for patient in the operatory, and putting a rubber dam and doing the whole procedure is sometimes difficult for normal procedures. But yes, root canal and all that, we do use rubber dam.
Perfect. So we'll connect with you as we go further. Thank you, Dr. Neil. Wonderful, wonderful. Well, the next speaker for today evening is Dr. S.M. Anwar Sadat from Bangladesh. He is an associate professor of oral and maxillofacial surgery and a consultant at the Square Hospital Limited, Dhaka in Bangladesh. He has advanced training and expertise in oral cancer surgery as well as reconstruction. I welcome Dr. Anwar Sadat.
Thank you so much. Good evening. I would like to thank to Dr. Ahmed from Canada especially, and the organizers, Dr. Puneet and Dr. Hasid especially, for giving me the floor. I am Dr. S.M. Anwar Sadat from Bangladesh, and basically I am in the maxillofacial surgery and special work in the oral cancer, but also lead the general dental practice in a private tertiary level hospital. So the topic on which I will talk is the changes in the clinical management in new normal in dentistry, that is old normal to the new normal, and the South Asian perspective. The recent COVID-19 pandemic and similar communicable diseases have always posed a high risk to the health professionals. It is known to all. And especially the aerosol generating procedures from aerosols contain bacteria and the fungi and the viruses. And dentists who treat patients using aerosol generating procedures are at very high risk of being affected by the patient and also cause transmission to others. And not only the dentists, but also the dental assistants we should bear in mind, and our staff, clinical staff, and the patients have the highest occupational risk for COVID-19. So the dental professionals in many countries all over the whole world, not only in the Southeast Asia, and have stopped their practice because of fear of spreading COVID-19. And this brings significant financial impact, no doubt. Not only the financial loss of the dental specialists or healthcare providers, it has impact on the patients who had midway through different procedures like the fillings, like the root canal treatments, orthodontic treatment, implants, maxillofacial surgery. So huge suffering of the patients for the whole 6 months. So we are on our way to start our practice, and not only in Bangladesh, also in other parts of the Southeast Asia. I think almost all dental surgeons and their specialists are trying to start their practice. I am a maxillofacial surgeon. I have stopped my maxillofacial surgery since March 15, and I am continuing my practice, and hopefully, and for the sake of Almighty, I am with my staff are safe, and that needs a very good protocol that the different international agencies and other health authorities have supplied to us. So what do we need to start the practice for our dental practitioners? That is the implementation of several technologies like the equipment can protect the dental healthcare providers, no doubt. And also the patients from aerosol infection, particularly those who are dealing with the root canal treatment and its allied specialists. And to take your dental office COVID-safe-free, COVID-free, COVID-safe zone for your patients, for your staff, for your doctors, and for your assistants. And how can we change this management? Change in the patient evaluation, change in the upgrading the environment, change in the protecting dentists and their staff, and also special equipment that Dr. Puneet was telling about some instruments like the electric handpieces. And first, I'm coming to the patient evaluation. We can evaluate the patients by trials method that other speakers already told. We can use the thermal guns on the infrared thermometer to detect the patient's temperature. But one thing we should bear in mind that we have lots of patients, almost 60 to 70% of the COVID positive cases are asymptomatic. So we should bear in mind that every patient's attendant who comes to our clinic should be regarded as COVID positive. And in that way, we can also evaluate the patients by the thermal scanners and the pulse oximeter. But I do believe these have very less importance in our daily dental practice. We can upgrade our environment for patients and the healthcare providers, especially by the IQAir system air purifiers, HEPA filter. This has very good impact on very good setup of our new dental clinics and offices, and also the foggers and the ultraviolet light. And this air purifier should be HEPA filter like the high efficiency particulate air, which can ensure you very good environment in your office. But we should not forget about the other methods to be followed, like the restricting using the fans in our practice. And we should keep our windows sometimes open during the operatory procedure. And also using the exhaust fans, which can keep your dental office more or less safe. And not only the environment, we the dental specialists and our assistants should be aware of protecting ourselves from COVID-19 by the personal protective equipment. And proper N95 is the key to protect ourselves from any suspected or COVID-19 positive patients, and also the respirators. And regarding the personal protective equipment, sometimes we have concentration on the face mask only, but the face shield has a tremendous role in preventing the affecting by the COVID. So along with the mask, and I'm going to talk about the type of the mask, and along with the mask, we should be very careful about using the face shield and goggles and the other things like the gloves, face protection, headgear, gown coverall, and shoe cover. Not only the protecting the face, I think your whole body can be protected by this personal protective equipment, as you don't know when the other surfaces of the body will be touched by you, or you can contaminate your face in any way. So it's better to protect your whole body by the personal protective equipment. And especially as a surgeon, I would like to say that it's very safe to operate a patient in the operating theater rather than in other times. As in this COVID period, we are very much aware of sterility. We are very much aware of our hygiene and everything. So I don't think the surgeon should be very much feared about doing the surgery in this COVID period. And regarding the face mask, we have the best one applied thing is the N95 mask. And there is no alternative to the N95 CM1860 and also other respirators which are very beneficial to protect yourself. And the other one is very now becoming very familiar with the dental surgeons who are dealing with the aerosol generating procedures like the PAPR, powered air purifying respirator. It has definitely, it has more efficacy, it has more power to prevent you from affecting by the COVID-19. But healthcare providers, but not necessarily all the examinations, in all examinations of the patient, in consultation, you need to wear the PAPR. Simple N95 mask, cover with a simple surgical mask, and you can wear 2 or 3 masks for extra protection. You can examine the patient. But especially this PAPR can be used in healthcare providers in some COVID affected areas, especially those patients are more susceptible to the COVID or the COVID positive patients. But strict care should be taken during the reusable elements and replacing the filters if you use the PAPR. And the filtering face piece respirator process like N95, not always you need to wear the N95. Say for in our country, in Bangladesh, first time we didn't get the N95 properly, but now it is almost available in our country. But the same equivalent quality mask can protect you from the COVID-19. That is KN95, FFP2, P2. Just these are the same quality from the N95 mask. And it is not recommended to use the P1 and FFP1 as these have only at least 80% protection from the COVID-19. So at least we can consider FFP2 and FFP3 and the N95. But the N99, FFP3, 3, and N100, those are best, but it's not available at this moment. So spatial working instruments along with the environment we can create for the general dentist and to have a safe environment for the dental practice. We can consider the spatial working instruments like the electric handpiece. And also the high volume sucker you can use rather than a low volume sucker of the salivary. It has good role in decontaminating of your area. And also there is an importance of the rubber band who can use it, but this cannot ensure the 100% protection of it. So you should have the personal protective equipment along with all these things can protect you from the COVID-19. And it prevents contaminated aerosols from the escaping of the mouth. And if we talk about the electric handpieces, definitely it has a very good role at this COVID pandemic time, as its greatest advantage is the less aerosol generation and also it's smoother and more precise cutting due to the stable speed. And I think the endodontist can say more about the electric handpieces. And though there are some disadvantages of this electric handpiece. And at the last of my presentation in 2 slides, I'll be talking about my take-home message. Before that, as a, I think many of the audiences are the maxillofacial surgeon colleagues, my colleagues, they can think of the tactics of the maxillofacial surgery in this COVID situation. And don't be afraid of doing the maxillofacial surgery at this moment, especially the who are very young and not vulnerable to the COVID at all. And please do every patient pre-operatively COVID test RT-PCR before doing the surgery. It's very easy, and it is advisable to admit the patient first, say for fracture patient or the maxillofacial surgery or the cancer surgery or the tumor. Firstly, you can omit the benign lesions at this period, but you should not ignore the cancer cases. So you can admit the patient, do the RT-PCR and to test the COVID, and then let the patient enter into the theater. During the operation, during the intubation by the anesthetist, please don't stay within the operation theater. Your whole operation team should be outside the operation theater and ask the hospital to ensure the negative pressure ventilation in the operation theater. And during the intubation, your presence will get harm to you. So don't stay within the theater. And during the surgery, you can avoid some operatory instruments like the hand pieces, like the drilling, and whether you can use the chisel, bar, and these things for cutting the bone and something like that. And be careful about the irrigation during the procedure. So, at the end of my talk, I can share with you some take-home message like for protecting your staff and the patient, there is no alternative to the room ventilation and appropriate personal protective equipment, along with the sanitization and the health hygiene. And dentists should keep up to date with all latest advanced technologies and the instruction for the healthcare authority, experts, and the government. And the most important thing I could realize that when COVID pandemic is shifted to endemic, a large number of the patients will rush to the clinic, as many of the dental clinics were closed and patients could not come to the hospital and the clinic. So there will be very rush of the patients to your clinic. So be prepared. The dentist should be prepared to provide adequate manpower for the following few months with the logistics and as well as increase their resources and utilization of the resources. That's my advice or my recommendation for all. Thank you so much. Thank you for giving me the floor and have patience hearing.
Thank you very much, Dr. Anwar. Just comment that one of the listeners wants to know that what about respirators? There is some controversy regarding, the airflow going out from the respirator. Should we prefer the industrial respirators or an N95 is the gold standard?
From my opinion, if you want my opinion solely, and I would like to use the N95 mask and that equivalent. And for extra protection, you can use 1 or 2 surgical masks over it, and it is enough for any dental procedures. Whether doing clumsy things for respirator, and there are so you have already told that there are so many controversies, and so better protect yourself from the N95 and equivalent with the facial shield. That is very important.
The second question is that is this IQ Air system, which is very popular in some parts of Singapore and the Southeast Asia, is it is it better than air ventilation, or is it equivalent, or the ventilation is the most important?
The ventilation is important. It is very simple, and anybody can avail it in their chamber. But the IQ Air system HEPA filters, this is high technology and expensive, and you can try it. Definitely, if you are able to do it, you can install in your chamber, and it will give extra protection to you. But there are so many filters and air filters in the market, but be sure that it is especially for the scientific and hospitals and dental care. And IQ system is best, as I know.
Thank you very much, Dr. Anwar. We'll connect with you as we move forward. Thank you very much.
Thank you.
The speaker for the evening is Dr. Rita Singh. She is currently the Vice President of the Nepalese Society of Implant Dentistry. She served as the President of the Nepal Society of Periodontology and Oral Implantology from the year 2017 to the year 2019. She is the member of Zonta International by empowering women through service and advocacy in Nepal. She is graduated from Bangalore University in India. I welcome Dr. Rita.
Thank you so much, Dr. Puneet. Thank you, Dental Practice, for getting all of us together. And it's really a pleasure to be amongst the celestial speakers of this area. In these very turbid, let's say, very turbulent and tough times, something as simple as communication can easily take up the back seat. We are so the different type of mask, in so many things we get lost. But we know that communication is the cornerstone of the dental practice. And this is the key actually to minimize the effect of the virus on our practices and our patients. If we are not proactive, if we're not responsive enough, and if we are not really sensitive about the emerging concerns of the patients, we may actually fail, through this period. So today I'm going to talk a little bit about the communication, how we can enhance it. And when we talk about communication, we think it's all about talking, but it's more to do with listening, active listening, or listening to understand. And a small incident that I want to narrate here is last month, one of our patients, he's a little bit obsessive, let's say compulsive about his health and hygiene, and he always wanted the first appointments. And of course, after the shutdown period, we were doing that. But one day, it so happened that when he came, there was an emergency patient, and the dentist had to attend this emergency patient. Now this patient was really infuriated, and he was boiling and brimming with anger. Now the front desk people, they knew that he wanted the first appointment, but probably they did not understand why exactly he wanted it. We, in communication, we need to actually be in the patient's shoes, and we have to see through the patient's eyes. So for somebody who's so obsessive compulsive about the health and hygiene, it's just impossible for him to understand what it takes to give time for somebody who's in pain. So while communicating, I think not only that we don't have one formula fitting for everyone, we have to actually hone our communication skills according to the patient's behaviors as well. And I think especially during these hard times when everybody is so stressful, we have to really give due importance to communication. Now PPE has a lot of hindrance to communication. When we speak, it's so difficult, it muffles our voice. The the shield, the face shield that we have, it kind of hides our smile, which helps us to connect to the patients. And also the facial expressions, which is such an instinctual way to empathize with the patient, that is also hidden. So all the visual cues are not there. So we have to be very mindful about the communication, because the patient may feel very uncomfortable with somebody who's covered with plastic covers, shields and masks. So maybe this is a time where we need to put that little extra effort to build the rapport, because building rapport is important, and this is the key to the success. And with PPs, it becomes difficult. And like the previous doctors talked about teledentistry, I think teledentistry is one such area where we can try and develop the rapport. Now, if we have the video calls, we can actually talk to our patients like how we used to talk in the pre-COVID areas, without the mask, without the goggles, and connect humanly. So not only we are trying to mitigate the risk infection to our clinics, but I think by doing these different kind of digital platforms, by doing the video calls, we can actually also build a rapport. And even after the PPE, of course, PPE appointments, we can do it. And as we know, words is not all. We have the nonverbal communication, the tone of the voice, the choice of the words, the energy level. All these things will help us to establish a good rapport with our patient, which is even more crucial at these times. Now, a very difficult situation may arise, and I'm sure it has already been there in some of the clinics in this Asia, in South Asia, that somebody in the clinic is tested positive. Now, what do we do? Of course, we have the primary concern is about the team member who is tested positive and quarantined, and in case of any kind of symptoms, the health assistance is required. But what about ensuring the safety of our patients and the other team members? That's also very important. So some questions which are there in the protocol, we can see that we have to always check what is the date of the last contact, how long was the contact, what was the distance, of the contact, if they are experiencing any symptoms. So we can go through all this and make sure, and like Dr. Gopi said, if that is the case, we have to do the PCR for the whole team. And I think in this kind of a magnitude of pandemic, we need to be very transparent to our patients. Of course, no one likes to associate their clinic or their office with COVID positive staff or the patient, but we have to have that level of trust and transparency towards them, because if they come to know that our clinic is a vector for the transmission and they were not notified, that's even worse. So it's better to be transparent and tell, and we owe that much to our patients, who trust us so much. So just to sum up, I would say communication is extremely challenging due to the PPEs and all the external factors right now. But then heightened attention to our behavior and compassion is very important. We have to be vigilant about our staff who may test COVID positive, and we have to follow the protocol, and we have to keep our patients and the staff very safe. And proper documentation again is very important. We should have a logbook for the patients, not just coming in, not just the consent forms, but also who are the assistants assisting them, who are the doctors, because if we have everything there separately, it'll be very useful at the time when we have to do contact tracing. So I would like to leave all of you with one last message, and that would be, how many of us actually thank our patients? Everybody knows dental clinic is not the safest place to be in right now, but a lot of dentists are seeing patients. So these patients who trust you, who really trust you with life, I think it'd be really nice if we thank our patients for that particular day, for that day. And of course, our patients are not going to expect it, but it'll be a nice surprise for them. And I think with this, we can actually bring humanity, to our profession. With this, I would like to hand over to Dr. Puneet.
Thank you, Dr. Rita, for a wonderful presentation and a very important aspect which is often ignored during this, pandemic time when everybody is under stress. That communication is the key to, success. You can easily get through the apprehensions of the patient as well as the doctor himself. Well, there are a few questions for you. First one is that, if a patient turns out to be COVID positive, he is COVID positive, and on teletriaging you found that out. What is your protocol? After how many days do you call him for his dental checkup?
Well, if the patient is positive, COVID positive, I have not had that kind of a situation till now. But I think then we really need to make sure everything is cleared out, and the PCR test after a couple of weeks is also cleared, and the symptoms have completely gone. In fact, it would be better to even talk to the medical profession who's been taking care of the person. I think that would be better. I don't know exactly how many days, but maybe other speakers can enlighten on that.
We will get back to it as soon as we continue. Well, another question is that you talked about consent forms. Now, these consent forms, what is the medical legal relevance? Do they have any significance?
I have been trying the Dentulu. This is one of the teledentistry platforms, and in that they do have a consent form for teledentistry, because we will be using the information, we may be using it. So because the video calls and the pictures are there. So I think we have to have some kind of a protocol for that, the consent. But I'm not very sure about in this area if we are really doing that. But I think it's high time we also inculcate these into our practice.
Thank you, Dr. Rita. Thank you very much for a wonderful presentation. We will come back to you as we progress. Well, the next speaker of the day is Dr. Gurkirat Singh from India. He is a professor and head of the Department of Orthodontics and Dentofacial Orthopedics at Sudha Rustagi College of Dental Sciences and Research, Faridabad in Haryana. He is registered with the Royal College of Surgeons of London as well as the Royal College of Physicians and Surgeons of Glasgow. He is a diplomat of the Indian Board of Orthodontics, a highly popular teacher with authoring the textbook of orthodontics, the first full color textbook by an Indian author on the subject, and a mini atlas on orthodontics. Welcome, Dr. Gurkirat.
Thank you, Dr. Puneet. And I hope I am audible.
Yeah.
So everybody's talked about what to do, but everybody needs those funds to do that. And that is where I come into the picture. I think I've also been chosen for this particular topic of financial impact because I'm one of the very few people who are actually running their practices from rented properties. So it's very simple, when you have two concepts where you have two people who are bothered about the COVID as far as dentistry is concerned. One basic people are the dentists whom we represent, and then there is also the industry. So for the dentists, I've divided them into people who are very young into the practice, that is less than 5 years. And then there are people who are 5 years plus, but 15 years or so into practice. And then those who are above 25 years into practice. And COVID has hit all of them in some way or the other. But I think it is uh, you know, the first group that has been the worst hit. The younger generation of dentists who just started their practices, have loans, have properties on rent. They are the worst hit. Whereas the people on the right hand corner, which is the senior people, have two options. Are they on the verge of, uh, are they ready for the change, or are they better equipped? Whereas the one in the middle segment, the mediocres, where we stand, people like me who are into practice for 15, 20 years, we are maybe have a clientele, but the impact has to be taken because we have no other options. We do not have any fallback incomes. We have a lot of responsibilities with our families, with our staff, which we have to live up to. The younger generation has been the worst hit. We have to be the fast adapters, the middle segment people, and the senior most can take life rather easy, or are have the funds to actually invest to recreate their practices in a new way. So this is a small, start that I'm going to show you, which is from ADA, and what they said was that actually, you know, April was the worst month as far as most countries are concerned, including India. We had no practice actually in the month of April. It was really, really bad, and things have been improving since maybe June, July. Things have been much better, and I've been talking to a few friends in the US, and they are practically back to 100%. And like Dr. Irfan mentioned in the beginning, Pakistan is doing, or they are making the changes, and they are able to practice to at least 80% efficiency of pre-COVID era with all the changes. But still, your gross volumes are down because of the patient care primarily, and not because we are not equipped to handle newer patients. So in India neighborhood that includes Bangladesh as well as Sri Lanka, we would say that in April was practically zero practice, practically zero. May was, we had a lot of emergency because we were shut for practically a month. June was better and people were gaining confidence. July was even better, but August has been below normal because maybe some areas have taken the hit of the second wave. What is projected as far as some of the data that is coming out is that we should be back to normal or back to at least 80% efficiency in the next 6 months. So it's going to be slow going, but a lot depends on individual practices and how we adapt to the thing. And since I have a visiting practice in Oman, I know for sure that there already the practices are generating the same kind of revenue, which might not be 100% of pre-COVID, but it is definitely in the 80% region, which is relatively, good at this present era, at least in terms of comparing them to India. So when you look at the major dental industries, all your trade shows have been postponed, all conferences have been postponed or have been made digital. So what I have done a small recce of what is the selling item, and everything that is selling is consumable, and that also related to COVID or PPEs or N95 masks. But overall, the the consumable industry is down to 20% of their normal. A lot of dealerships have changed hands or have ventured into PPE or COVID related uh, consumable sales. If they were selling composites, they are now selling face masks as well. So that's something which is different, but then that was expected because everybody is trying to generate revenue for their own stream. Equipment sales are down, but if you ask me, this is the right time to buy or invest because you're going to get the best deals on equipment. Everybody is selling something along with something. So if you want to buy a RVG, you're likely to get a light cure machine free. It's that bad. A lot of recovery is going to be linked to the spending power of the consumer, and that basically is dictated by governmental policies. So I know that in India, the government is trying to give you a lot of incentives, but till it reaches the general consumer, that is the general population, our patient base, it's going to be very difficult to come back onto our routine practices because everybody is holding on to cash. Nobody wants to spend their money. So if you're looking at a case which is you were trying to do maybe 12 veneers, I think the patient is going to take its own sweet time to come back, even though you might be ready to fluctuate your pricing a bit. But that patient is going to hold on to the cash because he doesn't know if his next salary is actually going to come as decided earlier. So that's a big difference. Reduced caseloads with increased costing. Now, this is the next thing that we're going to talk about. And we have all been told that space out your appointments. It's easier to say space out your appointments. If you're going to see less patients, you're going to generate less revenue unless, unless you have the heart to increase your rates. If you ask me personally, initially when we started, and I started as of 5th of May, I've been working and I've been working each and every day except maybe a couple of Sundays. The thing was, do we charge extra for our PPE kits? Do we charge extra for the consumables that we're going to be spending? And here I agree with Dr. Irfan that the new normal is not very different. Actually, we should have been taking these precautions earlier as well. So that is something that we have to decide on individual practice basis, how we are going to fend for this new role of creating or sanitizing or creating an environment which is patient friendly. Always remember, when it comes down to managing finances, decreased patient load generally means decreased earning, and decreased earning means decreased spending, and we need to streamline our protocols to be able to increase efficiency. And all this comes down to communication skills, patient screening, patient appointment basis. But this is the most important. So you have to realize that you cannot spend more unless you have either got loads of money stacked up somewhere, or you are ready to increase your charges because you are not going to be able to see the same number of patients as you were seeing pre-COVID era. Investments and loan restructuring, that is something that we all as professional dentists are very bad at. We never think about it. We just go ahead, we take a loan, and people are ready to give us a loan because they know that we are the white suited people. We are not going to cheat the banks, isn't it? But always remember, if you are talking about investment for next 6 months, my mantra would be just save, save, save. So if you have a good month, good week, good patient, don't be in too much of hurry to spend your earnings. You just need to save them, and save them so that you have some liquidity in case you require them. Always remember, restructuring is to buy time. So some governments are giving you 3 months leeway. I think in India we have now 3 months plus 3 months, so we have 6 months leeway. But this is going to increase your installments, quantum of installments at the end of whatever the 6 months might be. You can suspend them, you can delay them, but I doubt if you can actually decrease them. So the main mool mantra, the way I look at it today, is that you have to buy time from the people you owe money to. So whatever you get, be very, very judicious, because always remember, most of these people know that you intend to repay back. We as dentists are considered to be good people who are generally pay back their loans. So we have this leeway that we can renegotiate our our installments or our loans. So you need to buy time, and the next 6 months should be about survival rather than just whiling away money and buying equipment left, right, and center. This is another ADA survey which is actually projecting that the patients are going to be back to normal. They have done 4 scenes that they are likely to have, and 2 of them have tell us that basically everything's going to be okay, but it might not be as much spending by the patient as it was pre-COVID era, but it's going to get better from maybe as early as maybe November, December. So you can make out that November, December 2020, we're going to be coming close to our normal. So nothing to worry about. April was bad, that's okay, but we've been doing well even in India, except for areas which are actually where we have a problem, wherein we have a lot of COVID cases coming up. But otherwise we are improving, even though the numbers might seem to be increasing. But we are on the okay path as far as the recovery for the dental profession is concerned. And all the speakers before me have already mentioned that we are not spreading COVID as an infection. So, yes, we have to take precautions. Yes, we might not be able to do the same number of patients, but we are not helping them spread because we are taking all precautions. And it is courtesy seminars like this which tell us the viewpoints from various specialists and the guidelines that we provide each other with, that help us to tell that we can provide the best of services even in COVID era without causing cross infections if we take the right precautions. To end this whole thing, always remember, in struggle for survival, the fittest win out at the expense of their rivals because they succeed in adapting themselves to the environment. So this was Charles Darwin. The whole purpose of meetings like this is that we acquire new skills and we treat with all precautions, and we shall survive COVID as well. If we could get over HIV and hepatitis, COVID is a very small fry. So, friends, thank you very much for this opportunity, and I hope that your practices come back to normal soon. Thanks so much.
Thank you, Dr. Gurkirat, for a wonderful presentation. In fact, this is, the talk of the town because everybody wants to know what to do. And you talked about Darwin's theory. Yes, of course, it's a matter of patience and everybody is going to come back to normal. But there is just a quick question for you, that a direct one, that do you think that after investing more in, extraoral suctions, in electrical handpieces, in HEPA filters, have you increased the cost of patient procedures?
Personally, no,
Yeah. Okay.
no.
So you
And
are
there is a
you're
reason. Puneet,
yeah,
there is a reason. This is the time, like I said, for survival. So I want to keep my flock together. I don't want to lose patients.
right. Right.
I will make money if the patient is there. If I am doing my work, I will make money in due course of time. So I'm not being greedy. I just want to ensure that my patients feel safe. I do the best of treatment, even in COVID times, without too much of additional burden on the patient.
Right. Right. Thank you very much, Dr. Gurkirat, and we'll come along as we'll have more questions for you as we go along. And I'd now like to introduce the next speaker. The next speaker is Dr. Suresh Chan Muganathan from Sri Lanka. Well, he is a very famous consultant maxillofacial surgeon, a fellow of the Royal College of Surgeons of England and Edinburgh, also a member of surgical dentistry of the Royal College of Surgeons of Edinburgh. He has been appointed as an international ambassador for the Royal College of Surgeons of Edinburgh and a past president of Sri Lankan Association of Oral and Maxillofacial Surgeons, Sri Lankan Dental Association, College of Dentistry and Stomatology of Sri Lanka, Sri Lankan Academy of Aesthetic and Cosmetic Dentistry, a very big name who is also associated with the Ministry of Health in Sri Lanka. A very warm welcome to you, Dr. Suresh. Please.
Thank you very much. It's a great privilege to be associated with this online summit on new normal in dentistry. I hope you'll be able to share my slides from the center. Right. So basically, my first topic is talk about digitization. So if you look at digitization, digital dentistry basically is the use of dental technology and devices which incorporate digital or computer control components to carry out dental procedures rather than using mechanical or electrical tools. So if you look at using digital dentistry in carrying out dental procedures, which becomes more efficient than using mechanical tools, both therapeutic as well as for diagnostic purposes. So digital dental flow basically makes dentists gain time, and also it minimizes the number of steps compared to traditional one. So in this era of pandemic era, so we will be able to reduce the amount of time we spend on patients physically, so that we will be able to maximize the time what we have with us, and also which will also deter the cross infections between patients and the clinicians as well. And of course, the digital dentistry, it has its cost as well as it has an initial learning curve as well. So once you master the digital dentistry, you should be able to achieve better results and better outcome as well. And daily advances and improved softwares allow technology to be affordable, and also we are able to adapt faster with the new improvement in technologies. So if you can properly use it and rightly implement it, there could be a good return on investment. And the other important thing what we do digitally now is the digital patient education systems, where it's going to be growing very rapidly. In today's era, you can say they have everything available at their fingertips. And the practitioners, if you can actively manage the change to communicate with these 2.0 generation patients, because now if you look at it, most of these informations are easily shared on a digital platform through the social medias. So if you can have those educational materials available, we should be able to share preventive and therapeutic preventive messages and also therapeutic options easily through these digital medias. The other important thing, hope you are able to share my just go slide back please onto the two more slides back please. Yeah. Right. The other important thing is about dental practice management, which is also part of digitalization. Now a lot of practices are going into practice management systems, and also a lot of applications are coming into the market currently on digital on dental practice management, where we should be able to incorporate patient data as well as payment gateways into the system, so that again you tend to reduce the amount of contact you come with the patient, so that you should be able to transmit the information from one practice to another practice, and also to be able to send reminders to the patients through the electronic platforms what is available currently in the market. So therefore, digitalization not only revolutionizes the workflow, but it's an ongoing revolution that will undoubtedly shape the future of dentistry as well. Next, we come on to the digital teledentistry or video dentistry. Next slide, please. So basically, teledentistry is usually is a broad variety of technologies and tactics which is used to deliver virtual dental health and educational services. And it's not a specific service, but it's a collection of means to enhance care and education delivery. And in this COVID outbreak, we are able to utilize teledentistry to minimize the need for a patient to visit a dental surgeon physically, and to minimizes the risk of dental surgeons and health staff becoming exposed to COVID-19, and also it enhances the non-COVID patients to be managed appropriately. Next slide, please. And what are the modes which are available for communications in teledentistry? So basically, you can use audio or audio and video. Video consultations can provide better additional visual diagnostic clues and therapeutic presence, and it could be suitable for patients who are more ill or more anxious. So record keeping becomes a more important aspect in teledentistry, especially in critical situations, as consultation without active follow-up is of less value. The important note that when you're doing teledentistry, you should be able to know whether the patient is alone the patient is supported, or if this patient is being supervised by a healthcare worker, because the quality of data what you would receive from such engagement will be different from a patient, whether only you're discussing with the patient alone. And important to note that when you're doing video conferencing, that video dentistry, that is important that you have to maximize the quality of consultation. So therefore, you should have a good lighting, a good background with natural decorations. Position of the cameras becomes important, and it's important to have soundproofing because that becomes important for privacy as well as, or you can use headphones. And also important that you need to make sure that patient fixes the fixed position for the patient, which will prevent unnecessary movements as well. And this video dentistry or teledentistry also will give us an indication to assess whether this particular patient will need an urgent assessment or urgent mandate treatment, or whether it can come from a planned clinics or can do home visits, or whether the patient will need a multi-specialty care. And it's important to note that a lot of things have been talked about teledentistry, but the ethical implications on teledentistry due to lack of face-to-face communications or due to confidentiality. So therefore, we had to look at the consent of these such scenarios, this software, the security, what is involved, the documentation purposes, the boundaries within which we can do such tele or video dentistry, and the important thing is continuity of care, because sometimes you might give an advice to a patient over the phone, and then you may not follow up the patient. So what is the implications which will fall on us if we don't follow, we have continuity, and whether it has the same value or the equivalence. It's important that prospective councils should come up with on the next slide, please. So basically, next slide, please. So basically, users of teledentistries are basically can use it for dissemination of information on oral health and maintenance of proper oral health. We can advise patients inquiry and treatment options what is available, and we can manage dental emergencies, and also can give basically able to give basic instructions to avoid COVID-19 spread during the dental visits. Next slide, please. And importantly, as all I've been talking about, the teledentistry playing a major role in basically in patient triage, whether to assess the risk assessment, because we don't want a COVID positive patient coming into our clinic or suspected patient coming into our clinic. So we are trying to prevent that. So it plays a vital role in trying to prevent to filter patients with positive or suspected COVID positive patients coming into our clinic. And also it enables us to advise patients, right? If they are going to attend the surgery, what type of precautions we are taken, and what type of things you have to observe about hand hygiene, wearing of masks, about social distancing. And also it helps us to schedule patients, because then we should be able to, based on the triage, we should be able to schedule appointments, and also we should be able to patients who are vulnerable, especially, we should be able to make sure that they don't come with potentially suspected patients, don't come into contact with potential suspected patients. So it helps us in managing, especially in this COVID era. So thus, teledentistry has its role, especially in triaging patients, and but if you want to use it for consultancy or basically for further options of managing patients, then we need to have certain protocols which are developed by respective councils, so that we don't get into ethical implications by such act. Next slide, please. Then, what are the government initiatives which are done in Sri Lanka to revive dentistry? Next one, please. So we have been involved from March. The dental associations in Sri Lanka, we have been issuing guidelines within consultation with the Ministry of Health, and we have been keeping up to date with those guidelines. Time to time, we are modifying our guidelines and issuing necessary information to the dental fraternity in Sri Lanka, and so that we are able to contain the spread of COVID to a great extent. And also, the health authorities have the inspection team who visits the practices to see whether those practices complies with those guidelines. And also, initially, when the COVID started, we had the major issues of PPEs, shortage of PPEs, so that a lot of importers were given liberty and tax concessions, and also because in Sri Lanka we had to register all the products with the National Medicinal Regulatory Authority, so we were able to fast track all those processes, and trading of goods was expedited. So there was a mechanism which was involved in trying to get the necessary PPE instruments and equipments to fight COVID at that time. And also there is a moratorium in payment of loan installments. Currently, government has declared 6 months delay in the loan payments, and also we have reduced the interest rates on loans by 5%. So those are the initial initiatives which have been taken by the government. And also, currently, a lot of incentives have been given for production of equipments and materials locally. If you look at, we have a major garment apparel industries in Sri Lanka, so all the garment exports have been curtailed because of this pandemic. So they are now taken into the production of PPEs, not only for local market as well as for the export market as well. So those type of incentives have been given to the local manufacturing agents to go ahead and do such productions. Next slide, please. So thus, next slide. So what would we have to say that digitalization is an ongoing revolution in dentistry? I think that is anyway was evolving even before the COVID era. And I think that this digitalization would enhance it further with this current scenario. Will push people to invest more and more into digitalization in time to come. Teledentistry and re-dentistry has its role to play within certain limits, bearing in mind the legal implications. And government will have to play a major role not only to revive the dentistry, but because overall economy of the country has to be revived for the dentistry also to revive. Because if people don't have money, as Gurjit said, if people don't have money to spend, then of course they are going to curtail on unnecessary expenses. So basically they are going to come for only for emergency treatment to us. It's important that its overall economy has to be strengthened and has to proceed further for dentistry to evolve to revive in this COVID era. Thank you very much for the opportunity given. Thank you, Puneet.
Do you recommend some digital platform, or do you think that it's still evolving for teledentistry?
Teledentistry at the moment in Sri Lanka, we have platforms available for teledentistry as well as for video dentistry. The only problem at the moment we don't have is the guidelines for it, because legal implications which we have not really gone into it. Now, currently, Sri Lanka Medical Council is working on those guidelines, so probably we'll coming up with those guidelines very soon.
Thank you so much, Dr. Suresh. Thanks a lot. We'll continue as we move further. Well, the next speaker for the evening is Professor Asadul Zaman from Bangladesh. He is Vice Principal and Head, Department of Oral Pathology and Periodontology, Sapporo Dental College, Dhaka, Bangladesh, a PhD from Japan, a very highly learned doctor, and he would present basically how the dental colleges and guidelines have to be regulated. Welcome, sir.
Can I start?
Yeah, sir, sure.
Okay. Thank you, Dr. Puneet. It's my privilege for having us. So I have been listening to the wonderful presentations. All are related to how to open the dental clinics and what are the precautions we have to take to do the treatments. My presentation is totally on dental education. And still now, we are very much confused how to start the dental education. And students are around 4 or 5 months they were away from us. I'll be talking about the probable recommended guideline for dental colleges to be followed, and simultaneously to run the institution smoothly, we have to take care of the staff members, students, faculties, technicians. So I'm working as a vice principal, and I have the Department of Oral Pathology and Periodontology Department, Sapporo Dental College and Hospital, Dhaka, Bangladesh. As you all know, the COVID-19 pandemic generated unprecedented challenge for the delivery of education to dental students. And this represents a need for innovative teaching and assessment method to prevent disruption to dental courses. In response to COVID-19, dental education faculty of different countries has quickly transitioned the entire pre-clerkship curriculum to online formats. As you all know that the students, dental students begins their courses with preclinical teaching, in which they receive teaching on basic subjects and its related laboratory and practical works. So basic science curriculums can be decreased while integrating clinical teachings within this time frame and revisiting the basic science later in the dental school. Remote access to live tutorial and the problem-based learning is possible through the use of video conferencing applications such as Zoom, Google Classroom, and Messenger, etc. As a substitute for anatomy laboratories, online level images for cadavers and pathology specimen pots can be provided. Microscopic view of histology, microbiology, and pathology slides can be provided in online. Videotape, vignettes, and mannequin simulator as a patient surrogate can be used. We can also take examination update on the online, updating our content materials. We can take exam by using Proctotrack, webcam, or practicum. This is your online classes. We are taking in our institutions via Zoom. So clinical placement has been your cornerstone of dental training and since the early foundation of dental professions. As the number of cases of COVID-19 increases, dental students are not allowed to attend the clinic, representing a fundamental shift in clinical education from the bedside to online formats. Non-patient contact-based teaching may involve video conferencing applications and telehealth, consolidating and moving clinical didactic sessions online earlier to allow for later entry into the clinical environments, creating and using available virtual cases, modifying the academic calendar to extend later experience and defer clinical rotation. Access to an online repository, patient interview record and cases. And if to continue clinical teaching, priority of safety should be given. If patient contact-based teaching is to continue, adequate PPE and training must be provided, such as donning and doffing of the PPE. For smooth running of the dental institutions, the safety of the staff, students, faculties, and technicians are very important. So in short, safety measures should include ensure masks to everyone. Masks should be provided to doctors, teachers, students in clinical placement and hospital staff according to their works. Ensure good quality PPE for outdoor and OT doctor and staff. Provide proper donning and doffing area for male and female respectively. Outdoor materials, those come in contact with the patient, should be disinfected in between the patient. Place hand sanitizer in toilets, classroom, halls, and near entry and exit where possible. Encourage frequent and thorough hand washing, at least 60 seconds. Clean and disinfect college and hospital building, classroom, if possible, frequently, particularly the surface that are touched by many people, like railing, door, teaching and learning aids. Should promote social distancing. Implementation of social distancing practice may include staggering the beginning and ending of the college and hospital day, canceling all events that create crowded condition, create a space for a student desk to be at least 1 meter apart, and develop a biosafety committee to monitor and maintain all this. This is how we are seeing patient in our hospital with a proper safety gear for the doctors. And the take-home messages are proper application and utilizations of e-learning and teaching methods, and conducting an online obligations by updating the content materials, starting of academic activities in college in different shapes, continuing patient contact-based teaching by proper and adequate safety gear, modification and consolidation of dental curriculum to face pandemic situation in futures. Thank you. Thank you very much for having me. Thank you very much.
Thank you, Dr. Asad. You have, left us with a lot of food for thought because, there are so many dental institutions in South of Asia, and these
Yes.
recommendations possibly will come of use when these colleges are fully functional, and some of them are already functional, that how they should take care of their staff, their patients, and everything. Thank you very much, sir. We will come back to you as we move along. Well,
Thank you.
the speaker of the evening is Professor Ayaz Ali Khan from Pakistan. He is a member of the Faculty of General Dental Practitioners in UK. He is a fellow of the International College of Surgeons of the United States of America, a fellow of the Royal Society of Health. He is also served as an examiner for the MCPS College of Physicians and Surgeons of Pakistan, a dean of Institution of Advanced Dental Studies and Research, the editor-in-chief of the Journal of the Pakistan Dental Association. I welcome you, sir.
Thank you very much. Let me share the slides with you first. I would like to thank the organizers for having me on board. And at the same time, I must admit how clever they have been in getting about 3 conferences done in this 2.5 hours of work. I think each of the speaker has been phenomenal, and I was given the task of answering these 3 questions, which are in fact hidden 5 questions. So I could actually, if you ask me, I could actually hold a whole conference on these 5 questions that you have placed in. You see, what happened was that we all, starting from Irfan, coming right up to Professor Anwar, who just finished before me, we all are talking in terms of the new norms and how we have to change. But what has happened with us? I am a 40-year-old graduate. I graduated in 1980. And when I graduated, we graduated as wet-handed dentists. So our training was that of wet-handed dentists. I moved on to Africa, so I was hit earlier. And in that aspect, I landed in Africa, and here in comes HIV. AIDS was there, and we had to get our gloves on, we had to get our masks on, and we had to get our goggles on. And then I come back to Pakistan, and we have hepatitis C. So we get geared because of the hepatitis C and HIV. We are geared towards mainly bloodborne diseases. So the training was like that. Now what we have airborne and touch to add on to this. So we are practically going to have our future students trained on a slightly higher level than what we have been trained, and how we have been training our own kids at undergrad level on infection control. And although the disease, the COVID pandemic started in somewhere in January, early this year, it hit the subcontinent region and the area of Southeast Asia that we are somewhere in March. And as this thing came around, we had a series of webinars coming in. It became the fashion. And I think we had a second pandemic coming in. So we had the COVID pandemic, and the COVID pandemic was accompanied by the webinar pandemic. So I'll go along with the first question, which asked me is, how has webinaritis influenced learning? So chronologically speaking, we had in March, we had a massive excitement. I was on the Zoom half a day every day, and it was so precarious. So I had 6 meetings going on. There were video conferencing, online lectures took place. So as I said earlier, along with COVID, webinaritis became a pandemic. Next month, so it only took 30 days. Next month, we all started to become wary of these virtual meetings, and we started to become wary of the conversation that were being done online. We are not used to it. So we had to sort of adapt to it, and it became a sort of a burden. And people started talking about webinars, which they were doing till last month, as webinaritis, itis, inflammatory process that goes on. So the swelling was going up and the things were getting hot, and now the pain was starting to set in. And in all honesty, what we've been doing is, like, we are on Zoom right now. Since May 2020, Zoom fatigue came on board, and they are psychologists who are actually conducting studies on this subject. So this has become a psychological burden now. No, and then webinaritis became one of the most popular hashtag on Twitter. Next month, June, 2 months ago, 47 universities, I think it was 7 in the East and about 40 odd universities in the West, in where students started to demand a refund because they felt that my apologies. Hold on. I am such an illiterate on this thing. They felt that they have not got their money's worth. And people started to reject webinaritis or online lectures. There were examples that were right, left, and center. There were online conferences with 700 odd registrations, and only 15 odd people coming online while the conference was being run. So basically, the biggest challenge I feel today is to make an online learning into a meaningful, engaging, and a valuable exercise. We do talk about webinars and online training, but honestly, they are not taking the impact that they are supposed to be taking. So, what is the transition towards e-learning processes? It has been, it's not now, it was post pre-COVID as well. I have seen articles way back in 2004 coming down to 2008, 9 when it started to heat up. 2011, 12 have got a huge number of articles which was integrating e-learning into the dental education. And it has huge potential. There is no questions about that. And it can be used very successfully to be integrated into the dental school curriculum to increase the perception, like Professor Anwar discussed just now earlier than I was, about the fundamental concept and the students being able to apply this knowledge to clinical cases. Very recently, right up in 2019, and by the way, previously 2009, I actually saw a PhD thesis. I saw a PhD thesis from University of Birmingham by a young lady on the same topic. But in 2019, it was proposed that it should be a basic supplementary tool, a basic tool to enhance medical and dental education. However, majority of the studies, what they show is that there is a difference between the student's perception and the teacher's perception. So we are not, as teachers, with all of us as teachers, we have not been able to adapt to online teaching as much as we should have. Students are enthusiastic about it, but what we do is we have our concerns, so we hold on to our maybe information sharing, or because we feel that maybe this information may not be very good for the students, and maybe how do I divide the workload? So I believe that the fault is with us. We have not changed as teachers as much as we should have. We are, maybe because of the fact that we are not that much computer savvy, or we are not that much app savvy. And the younger generation is. So we need to adapt to that as well. So let me see how do we take the transition from e-learning to e-teaching. What the first step is that we need to determine what the dental students' preferences are regarding the use of online applications. What social media do they use, and what databases can be incorporated into e-learning of the dental school. It could just not be just the online lecturing that we most of us have been doing. A lot of things are around the world. They are available, starting from simulations, going up to educational games. There is augmented reality that has come in, and there is virtual reality in which the processes can be managed by just virtual reality. However, we talk about technology. It's not about technology. Technology only comes into life when people contact with it. And that is where we lack. The connection between the teacher and the student has not been as adequate as it has been on a face-to-face learning. Maybe because of the fact that we as teachers are used to these face-to-face learning techniques. And since this technology is new to us, maybe we have not been able to be that adaptive towards this new technology that has come in. Hold on, here we are. Now, how do we adapt? It's no longer that the big fish is going to eat up the small fish. Now, the speedy fish, the high-speed fish, is going to outrun the slow fish, however big the slow speed fish is. But speed enough is not enough. We need to develop an ability to spot and adopt to what is already available. There is multiple things. Just now, as I said earlier, the simulation, the virtual reality, these things are available all around the world. We need to just be able to adapt to these things. And we should not wait for people to create things for us. And teachers need to be trained to adapt to these technologies. So what we need to do, we need to take, we all asked Irfan earlier in the day, to pivot, change his direction. He had light coming from his back, so we told him to change the direction. So we need to start pivoting and see which direction we need to take. We need to innovate. We need to develop what is there. We need to innovate and create something from whatever is available right now. And then we need to be able to implement it. And to be very honest with you, we don't have time. So what we do need is a hell of a lot of speed. So all of us are going to transform ourselves as a starter into students. Now we become students of technology, and then we adapt our knowledge to those technology, and we do it at full speed. We do not have time to sort of do this. The third question that I was given was, is distance education a solution? Yes and no. We have the good, the bad, and the ugly of the distant education. The good is that it encourages faculty students interact. You can talk to your teacher directly. It encourages inter-student relationships, so there's cooperation among the students, active learning, prompt feedback. You get immediate feedback online. There is emphasis on time track, task time. So you have to time frame yourself that this is the timeline that I have to give. I was just reading an article the other day that since most of the corporations that have come online, the productivity of the employees have gone up by 30% because they give them a task in which they are supposed to finish in 6 hours. And employees working from home are actually working harder to get the online things done. Similarly, dental education, you can have the time frame. It's not going to be like that. That okay, I've got at the end of the year, 6 months, so that can wait. I'll do that later. Communication. The distant education communicates high expectation. It respects diverse talents, and there is always diversity of learning methods. And I think that's the good part. The bad part, and especially in countries that we all live in, there are challenges with connectivity. There are challenges by the for their pressures on the universities because the universities become more accountable. How do I know that my student online has actually learned the learning objectives that we are supposed to have achieved those objectives? So there is pressure on the universities. The academics they work around those pressure, and they are expected to respond to that mounting pressure. Online assessment, this Moodle and all their things, it's a difficult task. And so, and it's you have to log in, you are time bound, unlike what you do it physically. And then there is a lot of talk about how to assess, how to evaluate people. And that becomes, there are multiple theories around that work around that. We have to come around and we have to think, how do we need to manage that? The evaluation is going to be one of the most difficult tasks. And the ugly bit is that there is the highest rate of dropouts. That's studies have indicated. In higher education, when it's only distant learning. I do know that University of London offers external program in multiple specialties in dentistry, and I had the privilege of speaking to the dean many years ago. It's not now, and he said that he has a dropout rate of 60% over 3 years. So you have a 3-year program, and you have 60% people dropping out. That's a huge dropout rate, and we need to look into that. Why is that happening? There are social barriers, there are administrative barriers to access and be successful in higher education. Then, social barriers like the family pressures are there. This is family time. I'm sitting at home, and I have somebody coming in, my friends, my kids, and they have to be accommodated. That the administration at the other end at the university is trying to tell me something else. And if the students are shy, if they lack the ability to communicate with the lecturers, that's bad news. That becomes the ugly bit of the online distant education. Distant education is different. Now, new technologies have combined with changing transnational education landscape. So the advantages of distant learning and online education is that you can have, like, five countries are being represented on this very forum. Similar transnational education can be done. The whole landscape can be changed. We can do a lot of sharing. There can be a lot of partnership that can come up. There could be a lot of study models that have been taken in. It's an innovative place. You can have a huge market, and when you have a market, you will have competition, and when you have competition, you have no choice but to get better. So this is something that is good about distance learning. So as I said, there are yes and the no about it. These are the yeses of the distant education, and this is something that we probably will have to adapt to. E-learning is becoming more and more important in recent years. And because there are more opportunities available, more apps are being available, and student can be more adaptive towards that. They are more students focused, more student centered. So things are getting better. and it provides a great benefit for individuals worldwide. So I am not restricted to my classroom. I have an open classroom where I have a student in Singapore and one sitting in Timbuktu and one sitting in Africa, and so you have a variety of multinational people that can actually benefit from that specific thing that you are trying to teach. And it can be of whatever level, the highest level of education, and from there, even to general hobbies. So how do we adapt to these things? Oh no, before I do that, I need to tell you, have I missed out this thing? Hold on. No, I have missed out. Just give me a sec, please. Just give me a sec. There should be one more coming up. Oh, I have missed out. I have missed out on a slide in which I had spoken about how to become adapted and how to adapt to these change. But before I end up, I just wanted to end up with a story of the bridge on River Choluteca. Choluteca is a river that runs in Honduras, and Honduras is famous or infamous for a lot of rains and a lot of these what do you call those things? The storms that comes in. And this river Choluteca had its first bridge made in 1930, and every year it used to get washed off. So 1996, they decided to make an international tender. A Japanese firm came in, gave him his guarantees and warranties, and 1998, in April of 1998, they actually handed over the new river on Choluteca to the government. And it was inaugurated with a lot of pomp and show. And come August, September, rainfall come through. And Thunder Mitch comes in to picture. 75 inches of rain in 4 days. 7,000 people lost their life. Every bridge on every river in Honduras got washed away. Every bridge except the bridge on River Choluteca. It stood there firm. However, what happened was that the roads leading into the bridge and out of the bridge, they also got away. And when the storm settled, the river changes course. And the river changes course, and you have this bridge standing there on the side of the river with nowhere to go. So what you see here is a bridge which withstood Thunder Mitch, withstood 75 inches of rain in 4 days, the river breaking its banks, and there it is standing there doing nothing. And that is what I think COVID-19 has done to us. The conventional teaching methods are the bridge on River Choluteca now. And the course of the River Choluteca has shifted towards something new, something innovative. And we need to sort of make an additional bridge so that this bridge can also be used. I'm not saying that the conventional teaching should be taken away immediately, but I do very seriously think that we need to find ways to make it into a hybrid thing initially and then move on from there onwards to wherever the world is going to take us. So the new norm is try to think on something that works both ways. So way forward, this is how I think is we need to recognize that e-learning and e-teaching is going to be a major part of educational activities. And we need to identify first what are the student preferences regarding the use of the e-learning applications. We should not enforce it on them. We need to have this mutual understanding that it needs to be, the application needs to be both informative and easy to use for both the students. What is that? What the student need to be brought on board? We need to agree as teachers what are the course content that can be given purely online, what can be given as a simulation model, and what needs face-to-face contacts. And once we have agreed upon that, we need to then develop courses, we need to develop training modules, we need to develop assessments. That's the one of the most, because we get answerable for that. Assessment material that would keep the teacher and the student engaged. So it has to be kept very, very interesting. It can't be that lecture. Now, in a lecture, you have this student at the back, which I used to be when I was young, who is half dozing away. And online, it becomes very difficult for you to manage those students. But you need to keep the student engaged in what you're trying to tell them. And I feel the most important thing that's going to happen is we need to train the trainers. The trainers needs to be trained. The students will be trained later on, and then these things will start to take a shape later on. And with that, I thank you, and I finish my presentation. Thank you very much.
Thank you so much, Doctor. It was so enlightening and so much experience. You spoke with experience and how you have adapted. I was amazed at your digital handling of your slides and everything. It's amazing.
I still make a lot of mistakes.
No, so you are an inspiration. Well, while we move forward, there is somebody, a very senior periodontist from India, from the Government Dental College, Mumbai, Dr. Kumar Swami. He's the honorary professor, Department of Oral Implantology, GDC, Government Dental College and Hospital, Mumbai. He is the winner of the prestigious Indira Gandhi Priyadarshini Award for contribution towards the dental profession. A highly renowned person, clinical assistant professor, SUNY, Stony Brook, USA. Dr. Kumar Swami is a true COVID fighter. He was infected with COVID-19 last month and was able to conquer COVID. So right from the person who actually has gone through it, I welcome Dr. Kumar Swami to share his views.
Thank you. Thank you so much. I'm trying to start my video, but it says that the host has to allow it. So till such time that I am being seen, let me be heard. Good evening, everybody. Listening to over the last couple of hours to all the speakers has really enthused me. And here are my disclaimers to the viewers. I will not have any share screen. I will not have any PPT. I used a reasonable amount of PPEs for sure. I also want to tell you all that this is, like they say, tooth, the whole tooth and nothing but the tooth. The variation is my true story. Yes, I was diagnosed with COVID symptoms, I repeat. The test came later. And the point I want to emphasize here is the medical fraternity gladly appreciates and acts on the symptoms, not waiting for the results. Because results can vary. Results can actually go ahead and only help the regulatory authorities and the epidemiologists. What's important is for the patients to get treated and treated fast, which brings us to a point of acceptance. So if one thing I have learned is not to live in denial. Most of the damage happens when we live in denial. Yes, I know that there is an element of social stigma, unfortunately, associated with positive patients and their families, but so be it. At least we belonging to the medical fraternity, in a way, if you will, must spread the word of caution and care amongst all that we come into contact with, to tell them that the minutest, the smallest of the symptoms has to be reported and acted upon. And we all know the importance of the pulse oximeter today. We also know that we'll take care of all the patients who come into our clinics. Despite all that, and I love the way Rita Singh, highlighted that box. It would be unfair if I were to say that I got my COVID from the patient in the clinic. Equally unfair to say that, I went to the grocery twice, probably I picked it up from there. I went to the bank once, so perhaps all of this has got no bearing. because till today, there is no way to track, trace, and prove where you have acquired it from. Till such time that it happens, let us not put the blame on others. What I would say is, probably I was destined to have it, so I had it. Having said that, did I or was I a good patient? I think I was fairly a good patient, because we doctors are horrible patients, you know that. So I completely surrendered myself to the treatment plan, the protocols that my physician outlined. Yes, there was a flutter because of the shortage of the injection tocilizumab. You all know the immunodepressant, suppressant. We had a problem in acquiring that. But once that was pushed in, I started showing signs of reversal. What would be my learnings from my experience of COVID? A, friends and families are precious. They're the ones who rallied around. Otherwise, you all know hospital sailings can be very boring. But they were there, hanging in, and always telling me that you will come on soon. That encouraged me for sure. The second thing that I would like to say is, you may take all the precautions. You may take all the care. If it is writ, it will happen. Does that mean that if it is writ, it will happen, so why should I take care? Let me take a cavalier approach and do all as if nothing has happened. No, that would be wrong. As much as possible, we need to take the care and precautions, because if it does happen after that, it will be to the minimal damage. Where is the role of immunity in this? We all know, as scientists, as dentists, as medical warriors, there's a huge role of immunity. Can it be bought over the counter? Unfortunately, no. Can it be built up overnight? No, for sure. What do we need to do? A, the most important thing is have a positive mind. I'm not here to serve out a Saturday evening sermon, but what I have realized is a positive mind far stronger than any medication and any immunity supplements. At the same time, control over the diet, over our intake, not only volumes and quantity, but the timing. The timing of having your vitamin B, C, D supplements, monitoring them. Also ensuring that your family is doing the same line, because only if you do it, or if only one member in your family does it, it doesn't help. It has to be a team approach even at home. So the immunity builds up over time, and that will come into reckoning if at all you get attacked by this virus. And let's recall and remember, as we have read, this virus is wild and wily. It keeps changing its, as we call in India, avatar forms. It keeps changing its forms. And it is really foxed. Scientists at national levels, international levels, even to the extent of WHO, the constant yo-yoing of WHO into the status of be it aerosol safety or airborne transmission or the use or the uselessness of the masks. I mean, you have the whole list. Let's not get into that, because that is for the politicians to tackle. We as scientists will approach it head on to say that we will do all that is possible at our end to ensure that we minimize the damaging effect and the collateral damage of this COVID affliction. Now that you are at home, or probably you have time to ruminate, to reflect, and also to think about all that you could have done, you didn't find the time, you probably have time now. Apart from reading, I would strongly encourage you to pursue a passion. A passion which need not be hovering around your dental clinics, your treatment dilemmas, or other problems in your family members. You need to develop a passion because that would encourage you to have a wonderful feeling in the heart and stimulate your thinking, be it singing. I've been doing that. Be it an instrument. My friend Sushant, who must be watching, has now adopted the saxophone. You could adopt any of these methods to keep your mind busy and stimulated. At the end of the day, friends, your future, our future, I think, is predestined and preordained. But what we can do is make today a wonderful experience. What I call it, carpe diem. Let's enjoy this moment, the now. We've always been worried about the tomorrow, and we probably have not learned enough from the yesterday. So it is today that's an opportunity. So let's enjoy what we are doing today, be it this webinar. And yes, Dr. Ayaz, I loved your webinaritis because it is getting to a point, and if I go on this for the next 5-7 minutes, whatever few people have logged in also would probably log out. So I would spare them the agony, I would spare us the embarrassment, and I want to thank Badal Gulati, Dr. Puneet Batra, and all my wonderful colleagues across the Southeast Asia demographics, which has come to the fore. And yes, we need to hold our hands together, because I think if at all this virus is rendered ineffective, it is towards collective prayers. And collectively, we will conquer this. This too shall pass. Thank you.
It's an amazing feeling listening to you, Dr. Kumar Swamy. It was wonderful. Actually, you were telling from your heart what you've undergone, and what you have conveyed should actually be an inspiration to everyone. That whatever might happen, you have to learn to accept and learn to live with it. And also, it's like this, that it's part of your journey. So you better use your time as well as you can. Thank you so much, sir. We are really enlightened. Well, with this, I would say that we overshot time, but there was a lot of meaningful discussion which happened today evening. Thanks to all the panelists. All of you contributed, to you had a great contribution. And now, let's conclude. So what is the conclusion? What is COVIDified future of dentists? Is there no future? Or what is going to happen in the next course of time? What is going to come? There is a lot of speculation what the future holds for dentistry when this pandemic is behind us. There is a lot of talk about virus mutations. There is talk about numerous other viruses coming to the fore. But look at the positive side of it, that COVID has now, even though become a part of life, but health is now becoming a center stage for public policy. Everybody, all of us have stood, rethought about our health. All of us, even though there were lockdowns, we thought about our health. So as professionals, as healthcare professionals and dentists, we have to play our part in preparing both ourselves as well as our staff, as well as the patients who come to us for this new reality. We need to innovate and learn. Again, a very beautiful saying by Darwin, survival of the fittest. It's a time where you need to have patience, share your experiences, and come out as winners. So this is what has happened today evening. A whole group from this Southeast Asia has collaborated together, have shared their experiences, and I'm sure that, like all of us, this future is filled with promise and hope for all the dentists. Thank you very much, all of you. Thanks.